It's quite an emotive topic, we realised, as we prepared with John Harrison, a ICRP publication on dose quantities. So I'm not going to talk directly about that, though that will come into it. I want to talk about the use of effective dose in medicine. So I'll talk about the measurable quantities, their uses, and I'll talk about the derivation of effective dose, the approximations and uncertainties involved in it, and then deal with the sort of applications and questions about risk. Thank you. So the dose quantities that we can measure are the entrance surface dose for radiography, which is the skin dose, the coma area product, which gives us a measure of the radiation incident on the patient, the CT. We can measure the CT dose index, which is related to the dose of the tissues in a phantom, or the dose length product, gives us a measure of the dose for the whole scan, or in nuclear medicine, the activities of radionuclides. And these are sufficient for many of the applications. We can collect the data for patient dose surveys. We can make comparisons of doses for different examinations. We can use it for optimizing procedures, setting diagnostic reference levels, recording patient dose information, medical reports, tracking doses to individual patients. But there are variations in risk to the different organs around the body. The bone marrow, colon, lungs, stomach, and breast have a higher risk. And medical exposures are usually of specific parts of the body. And these measurable quantities, they don't give us any information which we can relate directly to health risks. Judgments have to be made about the examinations relating to risk, but if we compare the coma area product for radiography and the DLP for CT, or we compare the DLP to measured activity, or even if we compare DLPs for two different parts of the body, the risks are different. So generic values of effective dose, they can provide us with a tool which gives us a more meaningful method for making comparisons between doses. So the region of the body exposed in X-rays is usually well defined, and it's fairly precise activities of radionuclides are injected for nuclear medicine. Therefore, we know more about the radiation administered for medical exposures than we do for workers. And simulations are used to evaluate doses to individual organs in reference phantoms. And so in nuclear medicine, for instance, the ICRP acknowledged that effective dose could provide useful function to give a measure of the dose of the patient back in 1987. And in publication 52, and since that time there's been ongoing collaboration between committees 2 and 3 to derive coefficients which we can calculate organ and tissue doses in reference phantoms and effective doses for nuclear medicine examinations. And these use sort of compartment models tracking the movement of radioactivity through the body, assessing how much is in the different components and how long it stays in each. So we generate activity time curves for all parts of the system. So we know the distribution of radioactivity in the body, and then we can work out the doses to target organs based on this information. And there's been a whole raft of publications since 1988, and the latest one in 2015. As our knowledge and the models improve, we can get better and better information. For X-ray procedures, coefficients derived from Monte Carlo simulations have been used for assessment of doses to organs and tissues by a number of different groups based on things like entrance surface hair coma, coma area product, and dose length product. And so effective doses can be calculated, and this provides us enough information for a lot of the sort of everyday decisions that we need to make. And this has been instrumental in raising the awareness of the doses for different types of procedures in X-ray, in nuclear medicine, but giving people a feeling for the relative doses. But effective dose is a radiation protection quantity, so we don't quote uncertainties. And the precise calculations, they create an impression that the doses are known to rather greater accuracy than they actually are. We forget that, or users forget that the tissue weighting factors are approximations, there's uncertainties in measured dose quantities, there's uncertainties in patient anatomy and the organs exposed. There's variation in the radiation risk with age and sex. So look at a few of those. Tissue weighting factors, for instance. We want something which are nice and easy to use, easy to remember. So we have to divide the organs into different groups. So here I've just taken the normalized detriment from ICRP 103 and divided it by tissue weighting factors. You can see the weighting factors within plus or minus sort of 40 or 50%, but there are differences, and so there are uncertainties. But effective dose is only meant to be a rough indication. It's not meant to be a sort of precise value. If we look at the dose measurements and assessments from X-ray exposures, there's errors in the measurements we make. If we don't know whether the exact boundary of an X-ray beam is, so organs lying in and out of the X-ray beam, there'll be quite a lot of uncertainty in those. There's uncertainties in nuclear medicine and dose transit times, and also in the organ shape and geometry. Then if we look at the how the excess risk, so this is the excess risk against age. So that declines with age. It's slightly different for males and females. So the risks for effective dose, they're based on a population which is a sort of average of the whole of exposed population in the epidemiological study. So they're really for a reference person. Then, so when using effective dose for medical exposures, we've got to remember, therefore, that the potential risk for patients is generally lower for the reference population than for the reference population, because they're a greater age, so they've got reduced life expectancy and a lower risk. But for pediatrics, the risk is higher, and so we've got to give those special considerations. So effective dose doesn't tell us everything. We have to take the other information into account. Now, I use the differences in weighting factors and the other assessment of uncertainties to try and assess the uncertainty in different types of examinations. And you see there's quite a variation. These are different X-ray and nuclear medicine examinations. There's 20 to 60% uncertainty in effective dose as a relative indicator of harm. And you notice the ones at this end with the higher values are where we're just looking at a single organ, such as the head or a lung scan or a skull X-ray. And this is a similar thing, just looking at nuclear medicine scans and breaking down the contributions from the different components, the tissue weighting factors, the organ shape, the uptake. And you see the actual activity measurements is quite small. But again, the one with the highest uncertainty here is a thyroid scan, because all the radioactivity collects in the one organ. So the uncertainty in effective dose is about plus or minus 40% in general, in values derived for effective dose when applied to nuclear or to medical imaging procedures in general. And where there's a substantial proportion of the dosage just to one organ, then the uncertainty is greater, perhaps plus or minus 50%. But there's several nuclear medicine examinations, for instance, where the bladder or colon is irradiated during the excretion process. And we heard in the talk yesterday that this can contribute over 50%. Certainly there's quite a lot of organs where the colon or bladder contribute about 30 to 50% of the effective dose. And the variations in the voiding, the size of the bladder, the position of the colon, all create additional uncertainties. So, don't use effective dose when most of the exposure is to one organ. Nuclear medicine thyroid procedures with radioiodine, for instance, where all the activity is collecting in the thyroid, for mammography, where we're just really looking at breast dose, for head CT examinations, where we're looking at brain dose. So a number of that type of examination, we shouldn't use effective dose. And also, we shouldn't quote effective dose to the number of significant figures that I see in many papers that I referee. 2 significant figures is sufficient for values over 1 millisievert, and 1 significant figure for values less than 1 millisievert. So as I said at the start, ICRP has been preparing a report on dosed quantities. So I want to talk about some of the things that we recommend that effective dose is used for in that report. Referral guidelines and justification procedures to provide information on the relative magnitudes of doses from the different examinations. That's useful for referral guidelines and justification, and certainly we use it in the UK for justification of procedures for individual patients. If we're choosing an imaging technique, X-ray, nuclear medicine, really the only way we can make those comparisons is with effective dose. I said we use measurable quantities for optimization generally, but sometimes there's changes in the distribution within the body due to tube potential or additional filters, and then effective dose can also play a role. We use it for doses to research volunteers, assessment of the overall radiation-related health detriment, but in that we've got to take the age, the sex, and the health of the patients who are the volunteers, and many of whom are on clinical trials for cancer drugs or cancer treatments. We use it for reporting of unintended exposures, where the exposures are fairly low, or maybe below 10 or 20 millisieverts. We don't want to do a lot of calculation. We just need to get a general idea of what the risk level is, or the dose level is. We can use it for assessing the efficacy of imaging for health screening. We can use it for looking at the doses to carers. Exposures are often incurred by the family of patients undergoing iodine therapy treatment. So it's useful for that. But probably one of the most useful things, as I mentioned earlier, is effective dose provides a single value that can be used to compare different exposure scenarios. So we can compare different types of examinations. We can use it in training of medical practitioners so that they are familiarized with the dose levels of the different examinations. And we can also make comparisons with exposures from other different sources. And we can also use effective dose for medical exposures. Evaluating the risk of exposures in different countries is done by UNSCEAR. And it's also contributed to raising the awareness of doses from medical procedures in the USA and Europe. And in the NCRP report, which I think has just come out, the one in 2006 raised the awareness of the American population of the doses from medical procedures, and in the latest report that's just come out, it's come down significantly. So, effective dose, the risk of cancer relating to effective dose, they're quoted in fundamental recommendations of ICRP, and we provide a calibration factor. But unfortunately, quoting of risks, it's led users to make calculations of numerical values of risk, and this introduces a whole raft of further uncertainties. We've mentioned quite a few times the linear no threshold extrapolation that this week, but unfortunately it's the dose range right at the bottom of that, or the bottom section of that extrapolation that we're concerned with. Now, there's been a report from the NCRP of looking at different epidemiological studies, and now we're starting to see when you take, even if you take the data perhaps below 100 and below 50 millisieverts, there's still an indication that there is an effect from radiation. So the LNT model, it has uncertainties, but it's the best we have, and it certainly shows that there are risks at those sort of levels. Now, in deriving the risk calculations, there are other uncertainties. There are differences in the Japanese population, which is used for the predominant one contributing to the risk evaluation. So we have factors that we adjust based on the cancer rates in the Japanese population and ours. So that's an adjustment factor. We have another one for the dose and dose rate effectiveness factor, because low dose rates, they may not be as effective in producing cancer. But different committees such as ICRP and the Biological Effects of Ionizing Radiation Committee use slightly different adjustment factors. So evaluation of risk based on effective dose, numerical assessments of risks give a false impression of the accuracy. So we advise that general terms should be used, and these are considered reasonable indications of risk between about 20 years and 60 years. Above that, you can make slight mental adjustments for yourselves. But the influence of a patient's disease, health, and age on life expectancy has to be taken into account. And so these are the terms that we propose for the different dose ranges: negligible, minimal, very low, low, and moderate. So a CT scan would normally be in the very low. A radiograph of the spine might be in the minimal risk section. But the risk for individual patients used for effective dose apply to a sex average reference person. So differences for individuals arise from the age, the sex, the health status, and also there are genetic differences in the population. If we look briefly at sort of cancer incidence, so this again is, oops, no, I'm pressing the wrong button. How do I go back? That one. If we look at the risk, excess risk from radiation exposure against age again, for breast cancer, I mean, most of the risk is to females. For thyroid cancer, the risk for females is greater, but also by the age of 40, in fact, the risk for males is quite low. So for thyroids, it's more important to, say, protect the female members of the interventional team, for them to wear the thyroid collar, even though the doses are much lower. If we look at lung cancer, the risk sort of rises in midlife, contributions from smoking to that. It's also greater for females, whereas the risk for colon cancer is greater for males. Well, all of these vary with age and sex and have different forms. So the epidemiological data has been used to derive risks from exposure of individual organs and tissues by ICRP and BEIR. So an assessment of risk can be calculated using the risk coefficient for each organ and tissue separately based on age and sex of the exposed individual. The health status of the individual can be taken into account by the doctor dealing with the patient, and this provides perhaps a better assessment of the potential for cancer. But if we look at the different models, just to give you an indication of the variation between the ICRP, BEIR, and RADRAT, those are the excess risks for a whole body exposure for females and for males, calculated by the three models that are available. So they use a slightly different dose and dose rate effectiveness factor. They're average of different populations. ICRP has an average of a number of populations across the world, both BEIR uses the US population. So how do we deal with individuals? Well, this isn't ICRP, this is just me sort of throwing out a suggestion to me. I don't tend to calculate risks at doses less than about 50 millisieverts for an organ, so I don't actually do that at all in my general practice. But maybe if we take an example where a patient has had multiple exposures and say that they have an effective dose of about 50 millisieverts, and the lifetime risk that we calculate from the individual exposure of all the organs is 1 in 300, I mean, I might say that that risk could be anywhere between 1 in 100 and 1 in 1,000, but that's just me. It's not ICRP. So measurable dose quantities can be used for many applications. They're unsuitable for making judgments about examinations relating to the level of risk. Coefficients have to be derived to allow effective dose to be calculated for measured dose quantities. There's uncertainty of plus or minus 40%. For medical exposures, effective dose should only be quoted 2 significant figures. There's many sources of uncertainty. We could use generic terminology to describe risks. And so I'll leave it at that. Thank you.
Thank you very much, Colin. And we have already questions for you. Huh? Let me put the glasses. The first question: why to use effective dose as a surrogate of radiological risk assessment on patients when the actual excess risk to the actual person could, in medical procedures, be fairly well calculated instead? So you can answer the question and can give your opinion.
I use effective dose because I think that the risk calculations aren't to the sort of accuracy. They don't represent a true reflection of the accuracy, because I think there's a big variation. If we're using a dose, we're not saying that somebody has a 1 in 1,000 chance of getting cancer, whereas if we use a dose, we're just giving a relative impression, and I think that is all we can do with the level of uncertainty associated with effective dose.
Okay, thank you. The second question is, in terms of regulations, how does a regulatory authority properly work with effective dose in medicine, considering the shortage and cost burden of experienced and qualified medical physicists?
I don't think the regulatory authority needs to work with effective dose at all, because I think we monitor measurable doses and we compare those with reference levels. So I don't think that we need to consider effective dose.
Okay, so your answer is you don't think...
I don't think the regulator... the only interaction with the regulator where we use effective dose is actually reporting back doses from incidents where there have been exposures of up to 10 or 20 millisieverts, because the regulator in the UK, it may be different elsewhere, they have an understanding of effective dose, whereas they don't have an understanding of all the other dosimetry quantities that we might use.
But in medicine.
In medicine,
in this case. Well, we'll move to the third question. Is the 100 millisievert point discussed in the L&T debate per examination, cumulative, or per annum? Not you, because you refer to other number, but I understand the 100 millisievert that is usually referred to.
Yeah, from the epidemiological, or from...
Yeah. But in the case, I understand this question, but probably the author of the question may be sitting, I assume, in the room. I understand that refers, if this 100 millisievert if you apply this to the medical, because that is the way it is formulated, you would consider per exam, annual, or cumulative. If you...
I mean, applied to medical, I mean, in the UK, I assume this is relating to tracking doses over the period of time, but so being a...
Too high to think about some exams.
Being UK person, we don't consider exposures that people have had in the past. We would only consider the exposure for the next image that we're getting, and I would be amazed if there were any sort of plans to give people 100 millisieverts in imaging in one session.
100 millisieverts per annum would certainly be a cause for concern.
Yeah.
That is the value, high value, and Madame probably is sitting in the room, I think, the values that were discussed in the... you were there also on cumulative doses in patients with chronic diseases, multiple... So it's really...
It will be a cause for concern. I think it's probably not something that we're familiar with in the UK, though, those sort of levels.
Is there any question from the floor? I cannot see the hands. It's really dark, yeah.
Yes, there's someone here.
Here. Francois, you have the...
Yes, great talk, thank you. In the summary, you said that estimating the risk with the effective dose was accurate within more or less 40 or 50%.
But not estimating the risk, effective dose as a relative indicator of risk for a reference person.
Okay, yeah, for a reference person, you're right.
Yeah.
But what would be the precision of a very accurate measurement of the risk? I mean, there is also an uncertainty, because when you say the difference is 40 or 50%, that means you have a gold standard somewhere. But this gold standard, we know that this gold standard is more like a bronze standard than a gold standard. Yeah. So, and the uncertainty of the risk that is determined by the best information that we have certainly has an uncertainty that is at least the same order of magnitude.
Well, I think it's probably greater. I mean, I was suggesting that if the risk that we calculated from looking at all the organs and taking everything we can into account, we might not be able to say much better than somewhere between 1 in 100 and 1 in 1,000.
Yes, okay. So that clearly shows what you say, is that if
that's my opinion. Anyway.
Yeah, sure, I totally agree with what you say. But that means that if we combine these uncertainties by the rules that we apply in metrology, so the square addition, so that means that the additional uncertainty that we make by estimating the risk for a standard person with the effective dose would just be negligible. Because if we add 50% to 100%, and if we do it by squaring the uncertainty, as we usually do, therefore, there is no need to apply. If I just go, if I push the argument to the end, so that means we can be very happy just by using the effective dose, isn't it?
Yes, I agree. I always use effective dose. I don't go beyond there because I don't see that there's any point. We use the risk per sievert to sort of calibrate the clinicians or the professionals' view of it. But I think we should not go any further and just use general terms when we're talking to members of the public and patients.
Thank you.
Thank you very much. We have 2 minutes. So, is there any other question from the audience? From the panel, excellent. You have the floor also for asking questions.
Colin and I had a lovely conversation last night, so he probably sees this one coming. But what would ICRP recommend to do when there's a publication where somebody has taken effective dose over some cohort and multiplied it by the risk per sievert and said, these are how many cancers are going to happen? We know it's really wrong, but in the medical literature, this happens not rarely. So how would the ICRP... they don't always come through for a reviewer's desk someone that knows radiation protection quantities very well. And so these things just get published.
Yeah, I mean, if I was reviewing the paper, I would remove those and try and couch them in much more sort of general terms, because But I just find the public sort of latches onto these sort of figures, and they think, because we're quoting 1 in 2,000 or even more digits to that we know this thing very accurately. Whereas I was trying to make the point really in my presentation that we don't, and so we shouldn't do that sort of thing. But
what do we do when it's out there in the literature? Medical literature. You know, I thought about writing a letter to the editor for every paper I see it.
Yeah. Well, maybe that's what we need to do, yeah.
Yeah, the question is, what do we do when that's out there in the literature?
Yeah.
And of course, once it's out there and the media picks it up and there's a big media storm, a letter to the editor that shows up a week later or a month later has no impact. The message has already been conveyed to the public.
If you start up the argument, it becomes much more prominent, and people pick on what was said originally, and it gets more prominence in the long term. I don't know. So I guess
I was wondering if ICRP, has recommendations somehow to change that.
I think all we can try and do is educate those people that are actually the ones writing the papers, the medical doctors, any other scientists, in the appropriate use of effective dose. But you're right, it's already out there, and it's actually quite a difficult uphill task. I'm not sure we're going to be able to change it or solve that issue anytime soon, but I agree entirely.
And it's when it gets... Well, it's when it gets into the New York Times and sort of things, it's the problem.
Be more. No, but the ICRP has been clear with the message. Mm-hmm. Still, I agree that it should be probably added in education and training at all the levels in the medical community. And also using other media, social media, etc., when these big publications appear. But the message was clear in terms of that it is useful when we want to use it to compare similar populations, similar ages. So in a way, it's good to rescue the positive values that
it's an extremely useful tool. It's
clearly explaining which are the caveats, and probably we will have to continue educating and training the professionals. Well, the time is over. We need, there is a question there. Well, we will give you the last question. Matthews.
Thank you.
You have the floor.
John Matthews, I just wanted to speak a little bit in defence of epidemiology. But the broader question is being much more transparent in talking to the public. The reason the public are paranoid is they don't have the opportunity to engage with the experts. We heard yesterday, on Monday, we heard a passionate case for involving the public proactively in discussing these issues, and that's the way to solve the paranoia. And time will resolve the discrepancies between the different groups of experts, but the community need to be part of that process.
Yeah, I agree that we need to get the message across, but it is a problem that there are such wide differences in views by different components of our profession. So doing that is going to be a challenge, but it's one that we should take up.
Well, we need to close the session. Thank you again. Thank you very much.